morning. Thank you for giving me the opportunity to talk about my complication here. So, let's change these slides. So this is a 67-year-old gentleman. He was known to have type 2 diabetes mellitus, hyperlipidemia, hypertension. He had exertional angina symptom on walking 100 yards. He had positive exercise tolerance test. The echocardiogram showed mild LV systolic dysfunction with inferior wall hyperkinesis. He had a CT scan which showed significantly extensively calcified 3-vessel coronary artery disease. So from the outset, it was discussed with the patient that he might need bypass operation because of his type 2 diabetes and the 3-vessel disease. However, from that point, the patient was adamant that he would not want to have bypass operation. And if there was any option of percutaneous intervention, he would accept that or just continue with medical treatment. So the coronary angiogram was performed. From the coronary angiogram, you can see here that there is calcified CTO of OM1. And there are 2 lesions in the LAD, so mid-LAD severe calcified stenosis and distal LAD. It's the right coronary artery, so from it was difficult to engage because of tortuosity in the vasculature. You might be able to appreciate the calcified stenosis in the ostium. Then there was further calcification in the proximal segment, followed by further calcified stenosis, which is quite significant in the mid-RCA. So as mentioned, the patient was offered bypass operation, but he declined and was very keen to proceed to percutaneous intervention. So the left anterior descending coronary artery was tackled through the right radial artery using EVU 3.5. I got a Grand Slam wire down there because of the calcified vessel to have better support. So pre-dilated the vessel with 2.5 12 millimeter NC balloon. You can see the balloon didn't dilate well. So then I opted for IVL and treated the lesion with IVL 2.5/10. 3 cycles of 10 bursts were given and the vessel dilated. Obviously, I had to use guide liner for support to get the IVL balloon down there. And then 18 millimeter drug-eluting stent was deployed. So this was the end result there. So the patient was brought back as a stage procedure for PCI to RCA with rotational atherectomy. On this occasion, on left radial artery access was used because of tortuosity on the right side. And JR4 6 French guide catheter was used due to osteostenosis. I didn't opt for 7 French guide at this stage because of severe stenosis there. So just wanted to have less interaction with the ostium of the RCA. You can appreciate the angiogram here. So here I took Whisper MS wire and with support from Caravel macro catheter, I was able to wire the lesion, and then I was planning to replace the Whisper wire with the Rota wire. While doing that, I could feel, resistance on the Whisper wire, and I removed that, and then I inserted the Rota wire, which couldn't go through the lesion because the microcatheter was at the tip of the mid-RCA stenosis. I removed the Rota wire again and inserted the Whisper MS, which I was successful to take down again into the distal vessel. And at this stage, I was planning to take over the wire balloon to try and create a little channel for the microcatheter to take down and then exchange the wire. But when I was trying to take the Caravel catheter out, I could feel that the tip of the microcatheter remained behind there, which you can see on the angiogram here. So at this stage, I did parallel wiring, used Fielder XT down there, and then I took the micro sneer to try and sneer the soft tip of the microcatheter. I was unable to get hold of it because it was in the calcified portion of the coronary artery, and I couldn't slide the snare up on the micro tip. So at this stage, I tried to do some dilatation there. This is over the wire balloon I was trying to take down. Eventually, I was able to take a balloon down there, and I did some dilatation of this lesion in the proximal RCA. Again, despite multiple attempts, I couldn't get the snare down there. And at this stage, I had sort of other colleagues for discussion as well in the cath lab. I decided to take another axis from the right femoral artery and use AL.75 guide, but which was my fear from beginning. You know, it was not interacting very well with the ostium of the RCA. And at this stage, then I decided to stop. The patient was pain-free, he was hemodynamically stable, and I decided to sort of have a discussion with the patient and then bring back for further procedure or to consider bypass operation. The patient was also discussed with the surgeon, as the patient was hemodynamically stable and he was doing well. So it was felt that we can leave him on conservative management at the moment. I saw the patient a couple of weeks after this procedure. He was symptoms free, and we decided to continue on medical treatment at the moment. In future, if he has symptoms, so then we'll be considering further options, either again discussing the option of bypass operation, which he was reluctant to start with, or having another go on the right coronary artery. So just a few slides on the microcatheter. So Asahi caravel catheter is very useful catheter. It's due to its small profile and flexibility and kink resistance is really great to wire tortuous vessels. But obviously, as we saw in this case, you know, the micro catheter soft trip can get snapped off. Asahi tortuous is a very useful wire which has steel coil shaft, and that allows rotation of the microcatheter, which cannot be done in case of the caravel, and that could be one of the reason for the tip to come off. Although in my case, I felt it was the microcatheter getting sucked into the lesion when I was removing the initial wire for exchange. So Corsair and fine cross and turnpike catheters are some of the usual microcatheters which can be used in these circumstances. But it's one of the take-home message from me for this case is the difficulty for the interventional cardiologist when to stop and not to cause another complication, because it's very tempting to keep on trying and to try and recover from complication. But as it was said previously, it's very common to face a second complication after the first one, and especially if the patient is hemodynamically stable and symptoms free. So we always have the option of coming back to the case and sorting it out, and a more sort of relaxed environment rather than being tied while tackling one complication.
Great, thank you very much.